Pancreatic cancer kills 9 of every 10 patients within 5 years. Fewer than 3,000 surgeons in America operate on it routinely. The operation runs 6 hours. The complication rate sits above 50%. The night before, none of them sleep. In an operating room on a stainless steel back table sits a small kidney-shaped basin. Empty. 3 hours from now, a tumor will be lifted out of an open abdomen and dropped into it. Against the wall, gowned in pale blue, hands held above the waist and below the shoulders, is a third-year medical student watching all of this for the first time. That student is you. Level 1, the medical student. You are 26 years old. You owe roughly $300,000 in tuition, and the interest is accruing every month. You make zero. You take the exam that decides your residency in 8 weeks. Your surgery rotation runs 6 weeks at 80 hours each. Today is the first day. A nurse gowns you. She ties the back, opens the gloves, slides them onto your hands one at a time, past the elbows. She tells you not to drop your hands below the waist or above the shoulders. They are now sterile, and you are not. You stand against the wall. The attending opens an abdomen. The patient is 58 years old, pancreatic head mass, scheduled for a Whipple. You have read the chapter on pancreaticoduodenectomy. You will read it again tonight. The book is 2 inches thick. For 3 hours, you do not move. You watch a man's intestines get lifted, retracted, and parted. The smell is electrocautery, burnt protein. The attending names the structures out loud for the resident: portal vein, common bile duct, superior mesenteric artery. You try to memorize the order. Then it happens. The attending lifts the specimen: pancreas head, duodenum, gallbladder, common bile duct, and the gray walnut-sized tumor at its center, out of the body and drops it onto the back table into the kidney-shaped basin. The scrub tech labels it for pathology and moves it off the field. The basin slides out of the room. Pathology will read the slide tonight. After the case, you change out of your scrubs in a locker room with no clock. A granola bar comes out of your white coat pocket. You have a hernia to scrub on at 1 p.m. and a stage 4 pancreatic case on the schedule for the afternoon. In your apartment that night, you open the question bank. The score on the surgery block is 63%. You stare at the ceiling for 10 minutes and then open the book again. Every operating room you ever stand in will have a basin like this one. The understanding will come slowly, over 12 more years. You are 8 months out from match day. Level 2, the surgical intern. You match general surgery in March. You graduate in May. The first paycheck of your life arrives in late July, $67,000 a year, divided by 26. Your loans are still on hold. Your name on the wristband badge says Doctor Now. The senior calls you intern. You round at 5:30 a.m., 6:30 a.m. table rounds with the chief, 7 a.m. in the operating room. You hold a retractor for a gallbladder case. By 11, you are out, back on the floor, paging consults, writing discharge summaries, pulling drains. By Saturday morning of any week, you are usually past the 80-hour cap. 3 a.m. The pager goes off in your call room. Bed 42, post-op day 3, fever of 102. You walk the hallway in scrubs and a fleece. The pager is in your hand. By the time you reach the door, you have decided not to wake the senior. You order the workup yourself. 4 a.m. A code blue overhead. You run to the bed on a different floor. The patient is 91 years old, 2 days out from a colon resection in VFib. You step to the head of the bed and call the code. Compressions on. Epi every 3 minutes. 2 rounds of shocks. The senior arrives at minute 6. You keep running it. Return of spontaneous circulation at minute 9. The patient survives the night. 5:15 a.m. Different floor, different patient. This one had a do not resuscitate order on the chart. You walk in and check pupils, carotid, breath sounds, then note the time on your watch. The family is in the waiting room. You walk out and tell them. You do not remember the drive home. Surgeon ergonomics start now. You stand for 8 to 10 hours a day, hunched over the table, holding retractors at angles your spine was not built for. By the end of intern year, half to 4/5 of surgeons report regular pain in their neck, shoulder, or back. Your shoulder has started clicking when you reach for the overhead light. You will do this for 4 more years. The first solo decision in the operating room is on the other side of all of it. You are 3 years from the head of that table. Level 3, the senior resident. $84,000 a year, 6 years out of medical school. The PGY2 is on retraction. You are at the head of the table now. You take call from home. The PGY2 pages you at 2 a.m. voice tight. Patient on 3 South, post-op day 5 from a sigmoid colectomy, white count climbing, abdomen rigid. He wants to know if you should take her back. You decide on the phone, in your kitchen, in boxers, in the dark, yes. You drive in. By chief year, you log 242 cases. 65% are alimentary or intra-abdominal. Bowel resections, ventral hernias, small bowel obstructions, gallbladders. 3 years ago, you held a retractor for one of these. The knife is in your hand now. A trauma rolls in at 1 p.m. on a Saturday. 23-year-old male, gunshot wound to the abdomen, hypotensive on arrival. The attending is 20 minutes out. You take him to the operating room. You open him from xiphoid to pubis. You pack 4 quadrants. The bleeder is in the mesentery. You clamp it. The attending walks in at minute 18, scrubs, and stands across from you. He says, "Keep going." You keep going. The vessel is repaired in 20 minutes. The patient leaves the operating room with a pulse and a closed abdomen. The other thing chief year demands is research. Surgical Oncology Fellowship. Complex General Surgical Oncology has 65 slots open in the country every year. There are around 90 applicants for them. To be competitive, you need 2 years of dedicated research, which you took between PGY2 and PGY3. You wrote 4 first author papers in those 2 years. You did not see an operating room for any of it. Now you run the operating room by day and write a paper at night. Your partner is in another city for her own training. You see her once a month. You have stopped going to weddings. Match day for Society of Surgical Oncology lands in early March. Level 4, the Surgical Oncology Fellow. The email arrives at 12:01 p.m. on the second Wednesday of March. Society of Surgical Oncology, subject line, match results. Body. Congratulations. You have matched at MD Anderson Cancer Center. You read it 3 times. 3 other people you trained with also matched today. 1 into medical oncology, 3 years of hematology oncology fellowship after internal medicine, running the chemotherapy. 1 into radiation oncology, a separate residency, running the linear accelerator. The same diagnosis pulls the 3 of you in 3 different directions. You are the one going into the operating room. 2 months later. First day on the hepatopancreatobiliary service. The liver, the pancreas, the bile ducts. Your attending does 15 Whipples a year. That number is the floor. Some attendings do 60. Your salary is $90,000. You took a pay cut from chief resident moonlighting. The first attending paycheck is 2 more years away. You are at a major cancer center now. The patients here have already been to 2 other hospitals. Most of them have already had chemotherapy. Some have already been told they are not candidates for surgery somewhere else, and they have come here for a second opinion. The waiting room is quiet in a way that no other waiting room is. On a Tuesday morning, your attending lets you do the dissection on a case. 48-year-old male, distal pancreatic body mass, 2 prior lines of chemotherapy. The tumor wraps around the splenic artery. You take it down. Your attending stands across from you and says nothing for 40 minutes. After 5 hours, the case is closed. The patient survives. You walk to the cafeteria and eat alone. By graduation, you will have logged roughly 400 major operative cases. Whipples, liver resections, esophagectomies, distal pancreatectomies, cytoreductive surgery for peritoneal carcinomatosis, where heated chemotherapy runs through the open abdomen for 90 minutes after you close the tumor out. By case 300, you call the bleeder yourself a beat before the attending. The hours are not what people think. 40 to 50 a week. Call is roughly 1 weekend in 4. The exhaustion is no longer about the clock. It is about the weight of every case. You also notice something. Surgical oncology has the lowest median salary among general surgery specialties. The cardiothoracic fellow you trained with is making more than twice what you will make in your first attending year. The orthopedic fellow is making 3 times. On the Surgical Resident Forum, the word for fellows like you is masochists. 2 years pass, then you walk into a room without a fellow holding the retractor. Level 5, the junior attending. $260,000 a year. Some places, $450,000. You trade the fellow's badge for one that says attending. The operating room schedule for next Tuesday lists you as the surgeon. Below your name, in lowercase, Whipple. The patient is 58 years old, pancreatic head adenocarcinoma. He has a family. He has read about this surgery, including the survival statistics. Tuesday morning, 7:30 a.m. You are alone at the head of the table, bovie in your right hand, pickups in your left. The fellow stands across from you. The chief resident is on retraction. You burn through the gastrocolic ligament. The lesser sac opens. You perform the Coker maneuver, mobilizing the duodenum off the retroperitoneum so you can reach the pancreas from the back. The next part is the part that keeps people up at night. You dissect the superior mesenteric vein off the back of the pancreatic neck. The vein is the one that bleeds. If you go through it, you will lose a unit of blood in under 30 seconds. You go millimeter by millimeter with bipolar in your left hand and a peanut sponge in your right. The room is silent except for the bipolar. You divide the pancreas with the harmonic. The mass comes out. The scrub tech labels it and sets it on the back table into a kidney-shaped basin. You keep your eyes on the field. Then comes the rebuild. You hand sew the pancreatic duct to a loop of jejunum over a small plastic stent, 6 interrupted sutures, each 1 millimeters from the next. 5 hours. Estimated blood loss, 600 milliliters. By the time you close, your gown is wet to the knees with irrigation and sweat and a small amount of his blood. You go to the family in the waiting room and tell them it went well. That night, you cannot sleep. You think about post-op day 5, about the drain output. The numbers are in your head. Pancreatic fistula rate after Whipple, 21%. Delayed gastric emptying, 24%. Wound infection, 23%. JAMA surgery published a paper on what happens to surgeons after an intraoperative death. Profound grief, damage to self-esteem, loss of self-confidence and reputation, the specter of litigation, operative mortality at low-volume hospitals for this surgery, roughly 1 in 6. You are at a high-volume hospital. You will still not sleep until post-op day 14. 2 years later, you walk into Tumor board. Level 6, the mid-career attending. Around $660,000 a year. You are 41 years old. The number of Whipples you have done is over 400. You stopped counting somewhere in the second decade. 7 a.m. Tuesday. The conference room sits on the 4th floor of the cancer center. The lights are low. 2 screens at the front carry the case files. Pathology slides on one, contrast scans on the other. The room is full. Medical oncology in the 2nd row. Radiation oncology behind them. Radiology to your left, pathology to your right. The fellows sit along the wall. You pull up the next CT, 52-year-old male, pancreatic head mass. The tumor abuts the superior mesenteric artery for less than 180 degrees. You scroll through 3 slices and tell the room, this is borderline resectable. Chemotherapy first, then we go in. The room nods. Next slide. The patient is in your clinic at 1 p.m. He has driven 3 hours from a town you have not heard of. His wife is with him. He has a notebook. You tell him chemotherapy first. If his cancer responds, you will operate in 4 months. There is no guarantee that it will respond. He writes none of this down. His wife writes everything. He asks the question every patient asks. You answer in a range and a fact. The fact is 1 number. He nods. He goes home. You go to your next clinic, patient. That night, your partner asks how your day was. You say tumor board was fine. The patient's name does not come up. In 5 years, you will not remember his name. You will remember his CT slice, the way the tumor sat on the artery, and the fact that he had a notebook. Burnout among surgical oncologists runs at 36%. Depression sits at 24%. Your average work week is 62.6 hours. Across all of oncology, the leading malpractice cause is delay in cancer diagnosis. Sometimes the case the medical oncologist sent late ends up at your tumor board. The family looks at you for the answer. You will stand at the front of that conference room for 20 more years. Level 7, the Cancer Center Director. $700,000 a year. Some senior figures, anecdotally, report total compensation closer to $1.5 million. The endowed chair appointment letter arrives in a manila envelope on hospital letterhead. You read it standing at the kitchen counter, you put it down. You go to work. You are the principal investigator on a multi-center trial of neoadjuvant therapy for borderline resectable pancreatic adenocarcinoma. You have an op-ed in JAMA on National Pancreatic Cancer Screening Policy. There is a portrait of you in the lobby of the Cancer Center. You still operate twice a week, Tuesdays and Fridays. Your final Whipple of a 30-year career is on a Friday. The patient is 61 years old, your chief resident, 6 years out of medical school, scrubs in across the table from you. The fellow is on retraction. You start the case. The Coker maneuver goes the way it has gone 400 times. You hand the bovie across the table to the chief, then nod at the bleeder. You say, "You take it from here." 4 hours later, the tumor is lifted out of the abdomen and dropped onto the back table, into a kidney-shaped basin. You glance at it. There is a moment where you almost say something about yourself at 26 against the wall of a different operating room, watching this exact thing. You don't. For 30 years, you have stood at an operating table. For 30 years, you have told families their parent will not survive surgery. You forget the names. You still see the CT slices. You sign the op note. The chief resident comes by your office at the end of the day. He thanks you for letting him close. You tell him to go home. Your shoulder still clicks when you reach for the overhead light. It has been doing that since intern year. The hallway outside your office has a glass case with a plaque. Your name is on the plaque. The endowed chair sits next to your name. You walk out to the parking lot. Your car is parked in the same spot it has been parked in for 22 years. Somewhere in America right now, in an operating room you will never see, a third-year medical student is standing against the wall. Her hands are gowned in pale blue, held above the waist and below the shoulders. The attending is opening an abdomen for a Whipple. 3 hours from now, a tumor will be lifted out and dropped into a stainless steel kidney basin on the back table. She does not know that there is a Tuesday 7 a.m. in her future, a conference room with 2 screens. Pathology slides on one, contrast scans on the other, a patient with a notebook, a name she will not remember, a CT slice she will carry for years. She does not know that the operation she is watching today has a complication rate above 50%. 30 years from now, she will glance at a basin like this one. She will almost say something. She will hold it back. The basin is on the back table. 3 hours.